السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. نبدأ محاضرة abnormal labor. Abnormal labor or dystocia. This it means difficult, and tocia it means labor. So abnormal labor by the end of this lecture, the student should be able to define dystocia, summarize the important points in history and examination to reach the diagnosis, predict management option from different cases, scenarios, and determine the type of dystocia by different Partograph patterns. Abnormal labor. Labor becomes abnormal when there is poor progress as evidenced by delay in cervical dilatation or descent of the presenting part. يعني with the time ما يصير عندي progress بالcervical dilatation and the descent of the presenting part. The fetus shows signs of compromise, which means fetal distress. There is fetal malpresentation. Any presentation apart from vertex is considered as malpresentation. Multiple gestation, twin, uterine scar. The patient has a previous cesarean section and now she is in labor. And the labor has been induced, not spontaneous onset labor. All these considered as abnormal labor. Risk factors for abnormal labor: when the woman is small, so that the pelvis is small, when the baby is big, when there is dysfunctional uterine activity, efficient uterine contractions, 3 to 4 contractions in 10 minutes, each lasts for 40 to 50 seconds. If there is irregular or suboptimal uterine activity, this is considered as dysfunctional, malpresentation, malposition. Early membrane rupture. The membranes should rupture normally towards the end of first stage or during the second stage of labor. So early labor before good cervical dilatation indicates something wrong or abnormality such as malposition. Soft tissue or pelvic malformations such as uterine fibroid or pelvic fractures. Progress in labor depends on the power, which is the efficiency of uterine contractions, the passenger, the fetus, and this includes the fetal size, the presentation and the position, and the passages, the uterus, the cervix, and the bony pelvis. We will take each one in separation. Poor progress in the first stage of labor has been defined as cervical dilatation less than 2 cm in 4 hours, usually associated with failure of descent and rotation of the fetal head. 2 cm in 4 hours because we recommend vaginal examination every 4 hours during normal labor management. So we put this definition 2 cm in 4 hours according to the frequency of examination, divided into primary and secondary arrest. So far we are in the first stage of labor. Poor progress in the second stage of labor. Here it is diagnosed if the delivery is not imminent. The head will not be delivered after 2 hours in nulliparous labor and 1 hour for aparous woman. With epidural use, the birth of the baby is expected to take place within 3 hours in nulliparous and 2 hours in parous woman. Put in mind that epidural use will cause a prolongation of all the stages of labor. Because in the second stage of labor, the cervix is already fully dilated, so here the only parameter for progress of labor is the descent of the presenting part. Causes of poor progress in labor: we have dysfunctional uterine activity, abnormal fetal size, presentation and position. As far we describe this as the power, here as the passenger, and the abnormalities of the birth canal as the passages. This is a normal cardiotocography with infrequent uterine contractions. You see from here, each 1 cm equal 1 minute. So from here to here, 10 minutes contain only 2 contractions. So this is infrequent or dysfunctional uterine activity. How would you assess the uterine activity? By clinical examination, I put my hand on the abdomen and I count when the uterus becomes contracted under my hand for how long, and then the interval after how many minutes the second contraction came. By using external uterine topography, it is a transducer applied on the maternal abdomen, which counts the uterine contraction, and intrauterine pressure catheters. Here, specialized catheters measure the intensity of uterine contraction by using an intrauterine transducer. Here we see, this is cardiotocography, this is the tocography part, and here the cardiography part. We see during the 10 minutes window, 1, 2, 3, 4, and 5 contractions, okay? So here we have efficient uterine contractions, 4 to 5 contractions in 10 minutes, each lasting 40 to 50 seconds. This is considered as efficient uterine contractions. Here we have abnormalities in the fetal size. We see this is a macrosomic baby weighing about 5.5 kilogram for a diabetic mother. So this is a cause of abnormal labor. And here we have the conjoined twin, another cause of abnormalities in the size of the presenting part. Here we have malpresentation. This is the brow presentation. And here it is face presentation. Both of them are types of malpresentation. The normal presentation is vertex presentation. This area is called the vertex between two parietal eminences and between two fontanelles. So this area has the shortest diameter, which is the suboccipito-pragmatic diameter, to facilitate delivery. This is vertex presentation, which is the normal presentation. Another cause is the fetal malposition. Normal position, the occiput should be anterior. Here, occiput transverse, and here, occiput posterior. Both of them are types of malposition. You see here left occiput transverse, right occiput transverse. This is malposition. Here we have right occiput and left occiput anterior, and right occiput anterior, and here direct occiput anterior. Abnormalities of the birth canal. The bony pelvis may be abnormal, like in android pelvis, which is contracted with a prominent ischial spines. Abnormalities in the uterus, for example, fibroid in the lower uterine segment, will prevent the engagement of the presenting part. Cervical dystocia, which is an uncompliant cervix. This cervix will not be dilated to allow delivery, possibly after cervical surgery, for example, comb biopsy, excision of part of the cervix. This will cause stenosis and will not allow the cervix to dilate to allow normal labor. Cephalopelvic disproportion. This implies anatomical disproportion between the fetal head and the maternal pelvis. The causes could be a large head and a small pelvis. For example, maybe the baby is normal, but the pelvis is small. Or combination of two, previous fracture or metabolic bone disease causing contracted pelvis, Rarely fetal anomaly, for example, hydrocephaly, malposition, occiput posterior, again, will increase the size of the presenting diameter. Here, fetal abnormalities, this is ascites, may be a cause of obstructed labor, and here we have hydrocephalus. Again, these are causes of cephalopelvic disproportion. Diagnosis of cephalopelvic disproportion when the progress is slow or arrest despite efficient uterine contractions. يعني المريضة ما يصير عندها 2 cm in 4 hours. Cervical dilatation. When the fetal head is not engaged, still the presenting part is high despite progress of labor. Vaginal examination shows severe molding and caput. Overlapping of fetal skull bones is called molding. Caput is the swelling of the scalp over the presenting part. The head is poorly applied to the cervix. And when there is hematuria implying pressure on the bladder. The management of a prolonged labor. You know, the management is the diagnosis and the treatment. Diagnosis, Partograph will diagnose long labor before obstructed labor. We have a prolonged labor, which means labor extended beyond the time limits, and we have obstructed labor. This time the patient will never deliver because the labor is obstructed. The components of the Partograph, the first part here is the fetal part. The second part, what we are concerned about, is the progress of labor here. And the third part is the maternal condition. History should include the age of the woman, parity, duration of labor, how far she was in labor, any abnormalities, ruptured membrane, and if the membranes are ruptured, the amount and color of liquor, adequate amount of a clear or watery-like liquor, this is considered as reassuring. Duration of bearing down if the woman is fully, antenatal records and any problem happened during this pregnancy, previous prolonged labor or fetal death or instrumental delivery or cesarean sections, these will predict the likelihood of repeated abnormality. So diagnosis, first we have history. Second, examination, always start with the general examination. Sometimes the mother is exhausted and in distress with dehydration, ketosis, tachycardia, fever, scanty urine, all these should be corrected because it will cause morbidity to the mother. Abdominal examination, the frequency and the intensity of uterine contractions, the presentation, the engagement, and estimated fetal weight is very important. By clinical examination, we can estimate whether this baby is of big size, macrosomic, or it is of average size. The traction ring of bundle, this is seen between the tonically contracted upper segment and the distended tender stretched lower segment. As you know, the upper segment will contract and retract so that it will shorten and will stretch the lower segment over the presenting part. Here the bundle ring. This is the normal contour of the abdomen, and here the bundle ring between the tonically contracted upper segment and the flexed passive lower segment. This is the site of ruptured uterus when there is an obstructed labor. Again, by examination, fetal heart auscultation, you should auscultate during and for 1 minute after the end of contractions to detect late deceleration, which is important and indicate fetal hypoxia. Vaginal examination, dry hot vagina, cervical dilatation, the presentation and the position, the station, whether the head is high, whether it is engaged and progressing downward, excessive caput and molding indicating obstructed labor. This is the normal head. There are sutures to allow the approximation of the fetal skull bones during labor to facilitate labor. +1 when there is no space in between, +2 when there is overlapping, and +3 when there is severe overlap that cannot be reduced digitally. So +2 and +3 indicate obstructed labor, and the baby may not be delivered vaginally. Treatment. The treatment of poor progress in the first stage of labor, first of all, good hydration, put for her IV fluid, adequate pain relief, empty the bladder because the bladder may prevent the engagement of the presenting part, cross-match blood, and emotional support is very important. When poor progress is suspected, it is usually recommended repeat vaginal examination 2 hours rather than 4 hours after the last exam and plot on Partograph. We should not allow the patient to pass into obstructed labor or very prolonged labor. And so we repeat the examination if there is any concern after 2 hours rather than 4 hours. If delay is confirmed, again فحصتها ورا ساعتين وتأكدت إنه cervix not adequately dilated, the woman should be offered artificial rupture of the membranes to facilitate labor. If there is still poor progress in a further 2 hours, oxytocin infusion to augment the contractions. The infusion is commenced as a slow rate initially and then increase carefully every 30 minutes. كل نص ساعة أزيد drip of oxytocin. Continuous electronic fetal monitoring cardiotocography is necessary as excessively frequent and augmented contractions may cause fetal compromise. You should put in mind that once you infuse oxytocin, the contractions will become more powerful and more efficient, and the patient may develop a complication which is uterine hypercontractility or uterine hyperstimulation that may end with fetal compromise. So careful monitoring for the oxytocin drip is mandatory. Women can be offered epidural anesthesia if the progress failed despite 4 to 6 hours of augmentation. Cesarean section is recommended. Active management of third stage of labor is important because dystocia is one of the risk factors for postpartum hemorrhage. Treatment in the second stage of labor. Now the patient is fully dilated and the head is not delivered. Rehydration, intravenous oxytocin, if there is inefficient uterine contractions. Instrumental birth, forceps or ventouse, can be considered for a prolonged second stage if the presenting part is in low station, +2 and below. Cesarean delivery if the instrumental birth is unsuccessful or there is element of obstructed labor. Episiotomy for resistant perineum is advised to facilitate labor. Treatment of cephalopelvic disproportion. Oxytocin should be given carefully to a primary with mild to moderate CPD as long as the cardiac tachography is reactive. Relative disproportion. Sometimes the disproportion between the fetal head and the pelvis is mild, and this can be overcome by good uterine contraction. Oxytocin never given in a multiparous woman when there is suspected cephalopelvic disproportion. Parous woman is at risk of fracture uterus, easier than primary gravity. So you should not give it if there is cephalopelvic disproportion. Cesarean section is indicated when there is cephalopelvic disproportion with obstructed labor. Patterns of abnormal progress in labor. The main aim of Partograph is the early diagnosis of a prolonged labor before the complications of obstructed labor develop. So when I diagnose a prolonged labor, I can interfere to shorten the labor, whereas obstructed labor is at the final end of a prolonged labor and complications are more likely. Here, this is the alert line of the Partograph and here the action line. Normal labor should be on or to the left of the alert line, okay? Once we pass the alert line towards the action line, this is abnormal labor. First pattern, the prolonged latent phase of labor. When the latent phase is longer than the arbitrary time limit, latent phase is infrequent contractions, so the patient will be prepared into the active phase of labor. 20 hours in nulliparous and 14 hours in multiparous women considered as limit time for latent phase. It is more common in primary and probably result from delay in chemical process that allow effacement and dilatation of the cervix. This is a prolonged latent phase. This is the old Partograph, which had included the latent phase. So the woman at 1 cm, then after 4 hours, she reached 2 cm, another 4 hours remain on 2 cm. So this is a prolonged latent phase of labor. Management, best manage outside from the labor room. This is not indication to admit the patient. Simple analgesia is advised. Mobilization, reassurance that with the time the labor will get established and the progress will be more satisfactory. Intervention in form of ARM, artificial rupture of membranes, or oxytocin will increase the likelihood of poor progress later in labor and the need for cesarean section. So, in the latent phase, it is better to reassure the patient and not augment labor. Primary dysfunctional labor. Primary, it means the problem since the start of labor, when there is less than 2 cm cervical dilatation in 4 hours. This case admitted at 10 a.m. The cervix was 4 cm dilated, the head 5/5 palpable. After 2 hours, the cervix remained 4 cm, head 5/5 palpable. Another 2 hours, the cervix became 5 cm dilated. So here, in 4 hours, 1 cm, this is considered as abnormal progress, okay? So this is a primary dysfunctional labor. Later on, another 2 hours, the cervix dilated 1 cm, the head descend down, become 2/5 palpable, and later on, when the contractions become efficient here, the contractions, if we see early labor, it was infrequent with low intensity, here became more frequent, and here it is efficient contractions, 4 contractions with good intensity. The patient delivered spontaneous vaginal delivery. So the problem here was inefficient uterine contractions. Secondary arrest of cervical dilatation. The progress in the active phase of first stage is initially good. It is a secondary arrest. So initially it was satisfactory and then it will arrest altogether. Then slows or stop. Typically after 7 cm. For this case, admitted at 10 a.m., the cervix was 4 cm dilated, the head 3/5 palpable. After 4 hours, it becomes 6 cm. So this is accepted as a rate of dilatation. The head remained 3/5 palpable, and then with efficient uterine contractions, the cervix remained at 6 cm. So here it is a secondary arrest of cervical dilatation. The most likely cause is malposition, and for this case, cesarean section is done and a live male infant delivered 4.6 kilograms. So fetal macrosomia is the cause in this case. Arrest of descent of the presenting part, we see in this case 3 cm cervical dilatation. After 4 hours, it becomes 6 cm, which is satisfactory. The head was 5/5 palpable and then become 3/5 palpable. And later on, the patient became fully, here 10 cm cervical dilatation, but the head remained at 3/5 palpable. This is arrest of descent of presenting part. These are the patterns in summarization. Complications. This is an abnormal labor, so we expect complications. Always mention the maternal and then the fetal. Maternal complications, maternal exhaustion, dehydration, rupture of the uterus, which is an important life-threatening, increased operative intervention in forms of forceps, ventouse, maternal injury and laceration to the genital tract, shock, postpartum hemorrhage, puerperal sepsis because of a prolonged labor and frequent vaginal examination, and possibly maternal death may happen. Late maternal complications, urinary fistula due to pressure on the bladder for a long time that will cause necrosis of the bladder, and infertility due to infection and damage to the tubes. Birth asphyxia, these are the fetal complications, acidosis, intracranial hemorrhage due to pressure on the fetal head, meconium aspiration, fetal trauma, death, and neonatal infection. Late fetal complications may be cerebral palsy and mental retardation due to the trauma on the fetal head. Okay, thank you so much.